Welcome to the Simulation Center at Lviv National Medical University. My name is Gerasymov. I act as the Associate Professor of Pediatrics at Department of Pediatrics No. 2. Today we introduce you a 5-year-old boy admitted to the hospital with high-grade fever and dyspnea. His respiratory rate was 40 per minute. During auscultation of the chest below the right shoulder blade area, physician detected adventitious pulmonary sounds as it follows. The chest X-ray showed a picture of pulmonary fields as it follows. At this point, you must make preliminary diagnosis, order a laboratory test, and prescribe treatment. The preliminary diagnosis according to this clinical scenario is right-sided community-acquired pneumonia with respiratory failure. Additional laboratory tests for that boy would be complete blood count, C-reactive protein, and measurement of oxygen saturation. Treatment of that boy should include mask with oxygen, beta-lactam antibiotics, and intravenous fluids in the absence of oral tolerability. During transportation from admission department, the patient developed the following condition. How do you describe that condition? What is emergency treatment of that condition? This condition is called febrile seizures. Type of seizures is tonic-clonic, a combination of two major types of seizures. The condition is relatively benign in children aged 6 months to 5 years and unlikely to go on into epilepsy. Usually they simple and last less than 5 minutes. By definition, a simple seizure lasts less than 15 minutes, generalized in nature, a single occurrence within 24-hour period, and no previous neurological problems. However, complex seizures have duration more than 15 minutes, they are focal and recurring within 24 hours. In most cases, simple seizures are not treated. Just observe and give lateral position to prevent choking on saliva. However, if seizures are complex, you must make IV injection of diazepam in a dose of 1 mg every 2 to 5 minutes in a maximum dose of 10 mg. Let's say the boy finished jerking and was given 1 gram of ceftriaxone as a slow intravenous bolus. In 5 minutes after the injection, the boy started to be anxious, pale, and after that unresponsive. What is likely condition has developed in that boy? What is emergency treatment of that boy? The condition is called anaphylactic shock. You must call for help, lie the boy flat, raise patient leg, and give a shot of adrenaline potency 0.1% intramuscularly in a dose of 0.15 ml for that boy. You can also give a shot of epinephrine with a device with preset dose called EpiPen. On the screen you can see how it looks. To give a shot of epinephrine correctly, you must place your hand over the middle of the upper lateral aspect of the hip and with a fast movement make a shot, leaving a needle inside for approximately 10 seconds. After withdrawal and needle, you must perform a gentle massage over the injection place. After adrenaline shot, you must establish airways to make sure that they are open and give high flow oxygen, at rate of 5 to 8 liters per minute. Once oxygen is given, set intravenous line to give crystalloids, such as physiological saline, Ringel lactate, or 5% dextrose in a dose of 20 milliliters per kg. After that, you must give intramuscular or slow intravenous antihistaminic drug such as 1% solution of chlorphenamine in a dose of 2.5 milligrams, and after that 10% hydrocortisone in a dose of 50 milligrams. This sequence of drugs is dictated by the speed of occurrence of the effects in emergency situations. In hospital setting, the above measures must be accompanied by monitoring of pulse oximetry, ECG, and blood pressure. On the screen, you can see that patient has ventricular tachycardia. It is specific finding in anaphylactic shock, as well as reduced blood pressure and reduced saturation of oxygen. Let's assume that after the first shot of adrenaline, our patient started gasping or stopped breathing. What is your algorithm of actions? According to recommendations issued by the American Heart Association in 2020, you must look for breathing and check for pulse for 10 seconds. If pulse is definitely present but there is no normal breathing, you must provide rescue breathing, one breath every 2-3 seconds, or about 20 to 30 per minute, and assess the pulse again for less than 10 seconds. In the case when pulse is absent or pulse rate is less than 60 per minute with signs of poor perfusion, start cardiopulmonary resuscitation. If you are alone, CPR consists of 30 compressions and 2 breaths. Compressions must be performed at rate of 100 to 120 per minute. Before making a breath, establish airways using head tilt, chin lift technique. It is important that during compression you must allow the chest to complete recoil, otherwise this reduces efficacy of compressions. If there are 2 rescuers, give 15 compressions and 2 breaths. Check the pulse for every 2 minutes. According with recent recommendation, you must start compressions rather than breaths. Starting with compressions allow to spread remaining oxygen in the blood that improve CPR outcomes. If automated external defibrillator is available, use it as soon as it is available. During this session, we have discussed a 5-year-old boy with community-acquired pneumonia who experienced simple febrile seizures, anaphylactic shock, and cardiopulmonary arrest, with step-by-step explanation of management to be done before advanced life support is available. Thank you for your participation.